All right, so I've been asked to speak to you all about localized, or as I put here, non-metastatic breast cancer, and talk about the management approaches to this uh, rather complicated process. Now, I just wanted to let our friends at Haiti know that part of these lectures are to reinforce what it is that you do locally at home, but it's also an opportunity for all of us here in the States to give you a sense of what breast cancer care is like here and what the differences are, what opportunities are available for us, and what hopefully, as things evolve and things get cheaper, what opportunities may be available to you all as you further manage your patients with breast cancer. There's a lot to unpack here, and some concepts that you may not be familiar with based on our conversations about the patients at home. So I will, as I said, reinforce what you do, but also sprinkle on a bit of what it is that we do here in the States when we analyze patients with breast cancer. So I'm going to actually start off with a condition that you really don't see in Haiti, but one that is relatively common in the United States. And I'm going to do this in the form of a series of case reports. And I would appreciate it, since what I'm looking at does not have a timer for me, if one of my colleagues could just be a timekeeper for me and just let me know at 15-minute intervals, I would appreciate it. So this case one is a 55-year-old woman, and she presented for her annual screening mammography. And again, now that is something that is routinely done in the States. And in the process of having that screening mammography, she was found to have a cluster of what we describe as microcalcifications spanning an area of approximately 2 centimeters. She then underwent a biopsy, a stereotactic biopsy, which showed a grade 1 ductal carcinoma in situ. And the question is, how should this be managed? Now, this is a diagnosis that is typically found with mammography. Occasionally it will present with a mass, but oftentimes it is found when it is non-palpable. And just to give you a sense of what it is that gets done to find these conditions. So what you see on your left here is a blow-up view of a mammogram. Can you all see my cursor?
Yes.
Okay, great. So what you see on this mammogram, this is the normal architecture of the breast on a mammogram. And in the background here, you see these small little flecks of calcium. Those are called microcalcifications. And although they don't guarantee that they're cancer cells there, it is associated with cancer. And this is the pathology from the patient. This is ductal carcinoma in situ. These are ducts, and the cancer is largely confined within these ducts and not invasive into the rest of the breast cancer. And what I'm showing you here is the actual machinery that does the biopsy. It combines using a mammographic plate. The breast is compressed, and using the anatomy and the mammogram as a guide, a needle is stuck into that lesion, and a core of tissue obtained, in which we can then evaluate the pathology. And so, as I said, this was a ductal carcinoma in situ. It wasn't invasive. Typically, when this is found, a mastectomy is curative. For women who want to maintain their breast in the United States. If it's small enough, a local excision can be performed and you want to get clear margins. And in most cases, although this is still somewhat debatable, radiation therapy then follows to try and cleanse the rest of the breast. There is a risk of recurrence within the breast, and that increases the younger you are at the time it's diagnosis, the more poorly differentiated the disease is, and whether or not there are close or involved margins at the time that the tumor is excised. Now, this risk of recurrence is primarily in people who have had lumpectomies. It's not really an issue for mastectomy. We can check these non-invasive tumors for estrogen receptors, and if they are estrogen receptor positive, we can place them on medications like tamoxifen or arimidex that decreases their risk of recurrence and helps prevent the development of an invasive cancer. The problem with these tumors is that they can go on to become invasive cancers. So removing them before that happens is a potential benefit. So this is a kind of case that you won't see typically in Haiti without the use of routine screening mammograms, but it's a relatively common finding in the United States. So I'm going to go ahead now and put into your memories a little bit of a different concept of breast cancer than perhaps we have talked about on the phone. And if you do any reading in breast cancer, you will see that there are ways of subclassifying breast cancers in ways that we don't typically do when we discuss cases. And so there are these luminal A and B cases, HER2 positive cases, and what has been defined as basal-like, which historically we have called triple negative cancers, but not all triple negative cancers are basal-like. So luminal A patients are generally the best behaved breast cancers. They tend to have, they do have positive estrogen receptors. They happen to have, if tested, progesterone receptors that are relatively high. They are negative for HER2 protein expression, and they have low what is called Ki-67. Ki-67 is an immunohistochemistry marker that gives a sense of how quickly a cancer cell is proliferating. And so if it is low, you are typically talking about a low aggressive type of tumor. It can be used in breast cancer, but it can also be used in other tumors as well to assess just how rapidly the tumor is turning over. So luminal A's tend to be estrogen receptor positive patients with a lot of other good prognostic signs. Then there is luminal B. They also are estrogen receptor positive and HER2 negative, but they either tend to have high metabolic rates and reproductive rates with a high Ki-67 or low progesterone receptor. Again, there are HER2 negative luminal Bs and HER2 positive luminal Bs. If you are luminal B and HER2 positive, again, estrogen receptor positive and HER2 positive. And then there are the plain HER2 positive patients. Those are the patients who are HER2 positive but have negative estrogen and progesterone receptors. And finally, the ER/PR negative, HER2 negative patients, we sometimes will call triple negative, but we'll also call them basal-like. There are some histologies of breast cancer that are relatively rare, but are triple negative and have a good prognosis, and those would not be the basal cancers. There's a type of cancer called medullary breast cancer, which is typically triple negative, but tends to have a somewhat better prognosis than the conventional triple negative. Now, I'm telling you all about this and ways that you can stratify this in your minds, but um, this can also be found out by doing DNA analysis on these cells. For those of us in the States, so we can send these tumors off to get analyzed, and based on which genes are turned on and which genes are turned off, they can subclassify many of these in this way. But this is a fairly simple way of doing that subclassification. All right, so now we'll get into the remainder of the cases with that background. So this is a 67-year-old woman. She had a suspicious mammogram also. Biopsy was positive for an invasive lobular cancer, positive estrogen receptors at 98%, positive progesterone receptors at 92%. The HER2 was negative. She underwent a wide excision and a sentinel node biopsy was done, removing a 1.8 centimeter tumor with a negative sentinel node. And we'll talk about what sentinel nodes are and what is the management. So we have staged this patient as a stage 1A, and based on the criteria I used before, this would be a luminal A breast cancer, one that we would expect a relatively better prognosis with. And so how would we? Negative lymph nodes. So how do you manage early invasive breast cancer? And so this will be true not only for this patient, but subsequent patients that we talk about today as well. The decisions are based on multiple factors. One is staging, which you're familiar with. What is the tumor size and nodal status? And this assumes, for the purposes of this conversation, that all patients are not metastatic. So tumor size and nodal status. What are the estrogen receptors? In the States, we do look at what is the HER2 status. Is it expressed or not expressed? What is the breast cancer biology subtype? What I just mentioned, luminal A, luminal B, HER2 positive, HER2 not. And surgical decisions. All patients at home get mastectomies, but in the States, there's a choice of mastectomy versus lumpectomy. Some people you cannot do a lumpectomy. If the patient has multicentric disease, multiple tumors within the breast, that's a mastectomy. Some patients will prefer to have a mastectomy over a lumpectomy because they don't like thinking about whether their breast is going to get a cancer again, but other women will prefer to have a lumpectomy and maintain the breast if they can. And there are some basically geometric issues. How big is the tumor? How big is the breast? If you have to do a lumpectomy, if you have to remove 3/4 of the breast, no one is going to be happy with the cosmetic results of that. Then there's germline susceptibility. Are the patients positive for any breast cancer predisposing genes? In those situations, patients tend to think about whether they want to have not only a mastectomy for their breast cancer, but a prophylactic mastectomy on the other side, because their risk of developing a breast cancer over the course of their lifetime is higher than the average. If a woman's breast has had radiation in the past, that's not an ideal case for a lumpectomy, because lumpectomy presumes that it's going to be followed by radiation in most circumstances. And if the breast has already received radiation, it's not ideal then to do a lumpectomy. That patient should ideally undergo a mastectomy. And for the purposes of our discussion, we will presume that all the patients that we're talking about today will have had a mastectomy at HUM. So here's, so we're back to case 2 here. Oops, sorry. And so what about the management of this? So the first thing I wanted to talk to you, because again, if you read, you're going to hear about sentinel node procedures. And this is basically a graphic of what a sentinel node procedure is. So what happens at the time of surgery when the tumor is going to be removed, there is an injection of a material here that can spread and be tracked. It's either radioactive or it can be a dye, and some people do both. And what happens is, once the material is injected, it's going to follow a lymphatic path that takes it to specific lymph node or maybe two lymph nodes based on the lymphatic anatomy. Now, the whole idea here is that if this material follows that path, that means that any tumor cells that leave this tumor are potentially going to follow that same path as it leaves. And therefore, the lymph nodes that this injection identifies as the primary target for this material is also going to be the primary target for any cancer cells that leave the tumor. Therefore, if you remove just these lymph nodes that are being supplied by this area of the breast, you will have a good sense of whether any cancer cells have left. If the lymph node is negative, if the sentinel lymph node is negative, the likelihood is that there has been no spread beyond the breast. And so rather than do a complete axillary dissection to find out, simply by figuring out what's the most likely lymph node and removing it, you can get a sense of whether there are cancer cells in it. And if the answer is no, the likelihood is that the remainder of the axilla is negative. So, so as you see here, let's assume that this material is radioactive. There's a radiation probe. You can say, okay, these two are the sentinel nodes. You take out the tumor, you take out these two sentinel nodes, they're analyzed and give you a sense of whether to bother with any of these other lymph nodes. A negative sentinel node predicts axillary negativity elsewhere. If there is a lumpectomy, we typically go with radiation therapy to follow, except in an older population with very positive estrogen receptors. For a tumor this small and luminal A, we would go with adjuvant endocrine therapy only as the adjuvant treatment. And since this patient was postmenopausal, that treatment could be an aromatase inhibitor for 5 years, and that would be the management. I think that would be the adjuvant management both in the States and at HUM for a patient that presents this way. So we move on to case 3. And let me stop if there are any questions.
Yes, Dr. Siegel. I have a question. Personally, it was regarding the different subtypes of cancers, the luminal A, B. I know that sometimes there can be changes in the subtypes. Specifically like when patients have recurrence or patients who have had cancer for long times. So that is why sometimes new biopsy or it is necessary to do biopsy again. So we wanted to know, how frequent this is that there is a change in the subtype cancer, and is there a tendency, like is there more tendency for a cancer which was positive to become negative, or the contrary?
So I think if you want to know what is typical, the typical routine for any kind of cancer is to become more aggressive and de-differentiated with time, as opposed to becoming less aggressive. So patients over time may lose estrogen receptor and progesterone receptor positivity. And even if they don't lose the estrogen receptor positivity, you find that there are other mechanisms by which the cells become resistant to the effects of the estrogen receptor. So your estrogen receptor may mutate, may still be there and measurable as an estrogen receptor, but the receptor itself may mutate and no longer become impacted by the drugs that are being used. So I would say, and you would know if through personal experience, that even though you may not see a change in the estrogen receptor, there's obviously something that happens with the tumor that makes it more aggressive as time goes on and you continue to expose it to one type of therapy. the tumors learn resistance. Sometimes it's by losing their estrogen receptors and changing in this way from one subtype to another, but sometimes it's mutating in other ways.
Let me just translate for 1 second for the tip. Yeah. Donc, ça ne t'a discuté, c'est que Dr. Siegel dit que l'IK a changé. Mais la plupart du temps, quand c'est là a changé pour devenir plus agressif. Donc, il plus targeté dans c'était IR positif, IR négatif. Il n'est pas facile de faire ça inverse. Donc, les changer, c'est devenir plus agressif. Deuxièmement, pour capable de gagner tout, un cancer, bien que il était IR positif, mais il ne pas répondre à et combien à tête de chimiothérapie. Et des fois, il ne pas vraiment connaître ça va passer, mais il vient en forme de résistance. Donc, quand il y a un changement, mais la plupart du temps, il vient plus agressif.
Mais dans le cas, ça beaucoup de cas nous-mêmes, les persister comme ça, comme si nous pas vraiment qu'on une raison qui fait le résistant.
Pas toujours.
Nous pas.
Pour investiguer, mais pas toujours qu'à jeune comme ça. Et comme ça, on changer de régime.
Qui valable aussi pour tout.
Yes. Yes, we are good. Thank you.
Okay. All right. So this is case 3, slightly different. A 49-year-old woman who felt a lump in her breast. A mammogram confirmed the presence of a 2.8 centimeter mass, and the biopsy was consistent with a high-grade invasive lobular carcinoma. Estrogen receptors were positive at 76%. Progesterone receptors were positive at 12%. So they're positive, but much lower than they were in the other patient. The Ki-67 was 35%, which is relatively high, and the HER2 assay was negative. A sentinel lymph node biopsy was performed and was negative. The patient underwent a test called a mammoprint, which confirmed what we presumed to be a luminal type B carcinoma, which was HER2 negative. She has a mastectomy, and final stage is 2A. So what about this case is different, and how would we handle it? So on the left here, I am showing you what is a mammoprint report. So we talked about these luminal cases and the different subtypes of breast cancer, and we can make those determinations. I think I could have called this patient a luminal B patient based on the hormone markers and some of the other things we looked at. But we can, when we're not certain, send off some tumor cells to a genetic laboratory where they can do a DNA analysis and look at certain mutations. And we can tell based on the mutations or based on genes that are turned on or turned off, whether this is a luminal A or B or basal type carcinoma. And what that does is really give us an indication of whether the patient should be treated with hormones alone or hormones plus chemotherapy. So if you look at this, and it's all based on statistics, if you take this person's breast tumor, the average 10-year risk of recurrence untreated was 29%. But with the use of chemotherapy, these patients at 5 years, 94.6% of them would be free of distant metastatic disease if they got chemotherapy plus hormonal therapy. And that does significantly better than hormone therapy alone. So this is one of the ways we determine next steps. So the patient had a mastectomy, therefore no postoperative radiation therapy is necessary. We proved she had a luminal type B status, and we determined it by her genotype, but we also predicted it by her biochemical parameters. This would indicate that she needs adjuvant chemotherapy, whether it's AC or ACT or taxotere cyclophosphamide. I think any of those would be acceptable, and she would be a candidate for endocrine therapy following adjuvant chemotherapy. She was 49 years old. I think we would presume she was premenopausal at the time. Tamoxifen could be a choice. Quite frankly, sometimes we will induce menopause and give an aromatase inhibitor for someone like this. So, but the bottom line here, and the most important part, is that for this kind of tumor, both chemotherapy and subsequent hormonal therapy is appropriate, as opposed to the first patient where only hormonal adjuvant therapy was used. Any questions about that case and the difference from the first case?
No, we
Okay.
don't.
Okay. So now we're going to get into something that is very important in breast cancer. Unfortunately, not something that we're measuring yet at HUM, but I think if you want a full understanding of breast cancer, we're going to need to talk about it. So this is a 42-year-old woman, and she had a large mass involving her breast. It measured about 8 centimeters in diameter with a palpable axillary lymph node. Both node and breast mass were freely mobile, so you potentially could go to surgery. A needle biopsy was performed, confirming the presence of an infiltrating ductal carcinoma. There were no estrogen or progesterone receptors measurable on immunohistochemistry, but HER2 was overexpressed 3+. Okay, so HER2 is a protein. It's it's one of the family of epidermal growth factor receptors, I'm sorry, epidermal growth factor is one of the HER2 proteins. There are 4 HER2 proteins. HER2 is the one that we tend to measure in breast cancer and in other diseases for that matter now as well, but made its name in breast cancer. So let's talk about that. So when HER2 is overexpressed, it's overexpressed on the surface of the breast cancer cell, and typically these 2 proteins on the surface of the cell, they are cell surface antigens and receptors, and they dimerize and send a signal to the cell to replicate. So when HER2 is overexpressed, there is an increased influx of signal to the cell telling it to continue to grow. So what we have a drug in the United States that you may be familiar with called trastuzumab. And what trastuzumab is an antibody. It's a monoclonal antibody that prevents this HER2 from dimerizing. And by doing that, it inhibits cancer cell proliferation in this particular subtype of disease. And this has been a major innovation in the treatment of breast cancer. Prior to the development of this drug, patients who were HER2 positive had a much worse prognosis. Now, with the development of trastuzumab, many patients who are HER2 positive actually have a better prognosis than some patients who do not. The thing you have to realize is that HER2 is also expressed on cardiac myocyte cells, and that the binding of this antibody and its interference between HER2 and HER4 can cause cardiac disruption. So we can see, as a side effect of trastuzumab, we can see some cardiac dysfunction. So just to get down to management here, HER2 positive tumors greater than 2 centimeters typically receive neoadjuvant treatment with anti-HER2 antibodies. And typically now we have 2 antibodies. One is called trastuzumab, and more recently, the addition of a second antibody called pertuzumab. They both work synergistically in preventing these cells from growing. These two antibodies are typically given in concert with conventional chemotherapy, such as docetaxel and carboplatin. We do not like giving doxorubicin with HER2 antibodies because of this effect on the heart. You would potentially be giving two cardiac toxins if you give doxorubicin and HER2 antibodies. Unfortunately, we don't have these HER2 antibodies at home, so we are typically treating these patients when you see them with ATC. So why do we give chemotherapy beforehand? I think you've heard this before from us, because we do it with conventional chemotherapy as well. Number one, earlier intervention helps treat any micrometastases as quickly as possible. We could potentially downstage the disease for less aggressive surgery. When you have a pathologic complete response, that often is correlated with improved survival. So patients who have virtually no tumor or no tumor left, when the pathologist looks at it after neoadjuvant therapy, those patients tend to do the best. For those patients here in the States that were doing genetic testing to make a decision about whether to do a mastectomy or not, giving chemotherapy gives us some time to wait for those results to come back. And the NCCN is, although I would say that neoadjuvant therapy is used more frequently in oncologists' offices than the NCCN currently recommends it. If you look for neoadjuvant therapy in NCCN, it's going to be fairly limited in terms of how it's recommended, but it is used rather frequently in the States, especially for this type of tumor. So let's continue to talk about it. So she gets neoadjuvant therapy as per plan. And at the time she is completed with that therapy, she has no residual disease at the completion of therapy. And at that point, she chooses to undergo a mastectomy anyway, rather than a lumpectomy. And I'm proposing two endings here, because how we would handle it in the United States is a little different than how we would handle it at HUM. So in ending number one, the patient has a complete pathologic response. They don't find any residual disease. In ending number two, there's been a clear response to the treatment, but when you actually go in and slice the breast and look for the pathology, that you find a 1 centimeter focus of viable tumor remaining in the specimen. So how do we deal with that? So first of all, let's talk about after mastectomy, whether anyone should be getting radiation therapy. So the patient had a big tumor, as you recall, had a palpable lymph node at the start. We do give some women radiation therapy even after a mastectomy, and the benefits of post-mastectomy radiation do not outweigh the risks unless the people have more than a T2 tumor and have greater than 3 lymph nodes found at surgery. That's the situation where we would use postoperative radiation therapy, because the risk of recurrence in the skin is much higher in this particular group here, greater than T2 or greater than 3 lymph nodes at surgery. And certainly if anyone at the time of surgery is found to have persistent lymph node involved by tumor who don't get a complete response, those people should get adjuvant radiation therapy as well, even though they've had a mastectomy. All right, so let's go back to our various endings. So at HUM, regardless of whether we found any tumor or didn't find any tumor, the ending would be the same. This is an estrogen receptor negative patient. The patient's had shrinkage of tumor. The tumor has been removed by mastectomy, and we would end there. And there's no role for endocrine therapy. In the United States, however, even if there was nothing to be found, we typically complete a full year's worth of trastuzumab. If, on the other hand, we find disease in the breast, sorry, I'm just checking time. if we find disease in the breast, still after neoadjuvant therapy with HER2, we use a drug called trastuzumab emtansine. And this drug is an antibody drug conjugate, which is an interesting concept. So in this purpley pink color here, you have the antibody trastuzumab. But attached to this trastuzumab is a drug called DM1, which is a cytotoxin, a fairly potent cytotoxin. And it is linked to the trastuzumab by this little linker molecule here, this little line. And so what happens when you give this antibody, it attaches to HER2, it then gets internalized, and when it gets internalized, this DM1 is then released. So what you have is selective delivery of this DM1 molecule to the cancer cells because they're being bound by this HER2, anti-HER2 interaction. And so there's selective delivery to the breast cancer. And we have found that people do better if we give them this drug, if we find that there's still residual disease at the time of surgery after neoadjuvant therapy. So that's another version of anti-HER2 therapy. All right, so that was a lot. I believe this is the last case I have. So let me just ask if there are any questions about HER2 positivity. If not, I will move on.
No.
Go ahead.
Manley has a question for the HER2 treatment.
Yeah, I want to know if we can do palliative treatment with trastuzumab for
Yes. Yes. So if a patient presents with metastatic disease, which was not part of this conversation, and they are HER2 positive, absolutely yes, we use these drugs as part of the treatment of their metastatic disease effectively.
Okay. Yes, we're good, thank you.
Okay. So this, I believe, is my last question. Again, a 48-year-old woman has a mammogram. A 2.6 centimeter mass is noted, and the biopsy demonstrates a high-grade invasive lobular carcinoma, no estrogen receptors, no progesterone receptors, and no expression of HER2. Classically, what we would call a triple negative breast cancer. She has no clinically positive lymph nodes. So what do we know about these triple negative breast cancers? Well, we know that for one, triple negative breast cancers tend to be associated with a higher risk of having breast cancer germline predisposition disease. There is so much triple negative breast cancer in Haiti. From the moment I was there, I have wanted to do a study looking at breast cancer susceptibility genes in the population. I don't know if that ever got off the ground, but this is just such a frequent phenomenon in Haiti that it makes me wonder, especially how young some women are with breast cancer on the island. So it's always amazed me. But again, if an individual harbors a germline mutation for breast cancer and ovarian cancer and other cancer susceptibility, some women may choose to have bilateral mastectomies. They may choose to have bilateral oophorectomies to minimize risk. And if you carry these germline predispositions, there's a 50% chance of transmitting them to children since they're dominant genes. So that's one thing that we think about when we see triple negative breast cancers. The other thing is that, as you know, and what we have been doing in Haiti, for tumors that are, more than 2 centimeters, which is most of the breast cancers we see in Haiti, we typically use neoadjuvant therapy for the reasons we talked about before. And typically we use ACT, and that's not terribly different here in the United States. So she receives neoadjuvant chemotherapy as per the clinic's plan. And at the completion of therapy, has no palpable residual disease, and she too undergoes a mastectomy. And again, I'm going to divide it into 2 endings. One in which there's a complete pathologic response with no residual pathologically determined disease. And again, for those people who have a complete pathologic response, they have a better prognosis. In ending 2, there is a clear response to therapy, but again remains a 1 centimeter focus of viable tumor in the resected specimen. So how do we handle that at HUM and in the States? So at HUM, regardless of the ending chosen, again, this would be the end of therapy. You've given them adjuvant ACT. The breast has been removed. There may be a little focus of residual cancer, maybe not, but either way, I think we would all say our job is done, and we would just monitor the patient for any signs or symptoms of recurrence. There's no role for hormonal therapy here because the estrogen and progesterone receptors were negative. In the US, if there's no evidence of residual disease, we too would stop. There is nothing left to do. The patient would be followed. If, however, we were to find some residual disease, we are typically now giving a drug called capecitabine for 24 weeks. Capecitabine is in essence a prodrug for fluorouracil. It gets broken down in the body to fluorouracil from its oral form to its circulating form. And these patients would then take pills for a period of about 24 weeks until the completion of that, at which point the patient would be followed. So I hope this projects well, but for those of you who I put to sleep, if you look at this slide, this summarizes most things that we talked about. For the purposes of abbreviations, CHT means chemotherapy, ET is endocrine therapy, and I think everything else is relatively straightforward. So you can have this to refer to, and I believe that is it. So at this point, I am happy to take any questions about this or, quite frankly, anything else related to breast cancer that you were curious about in the situation that we may not have talked about. I hope it was a good balance between what you're doing at HUM and in comparison to what's been done here in the States. And now I'll be quiet and let you all ask questions if you have them.
Thank you, Dr. Siegel, for all of those cases. I wanted to get back on the last case, the 5th one, just to clarify something. It seems to me like if a patient is proven to be triple negative, even, if you are only, if the tumor mass is only more than 2 centimeters, there is an indication for neoadjuvant chemotherapy. Is that right?
Yeah, so there is some data that would suggest that there is a survival benefit to intervening early with chemotherapy in this group of patients. You know, historically, in a situation where patients have where there was radiation therapy available and patients have the potential to have a lumpectomy, historically the main reason for giving neoadjuvant therapy was to try and shrink the tumor down so that a lumpectomy could be performed without having to do a mastectomy. But there are some data, at least, that would suggest that earlier intervention with neoadjuvant therapy may have provide some survival prolongation as well. So, so in those circumstances, I think we are tending to give neoadjuvant therapy earlier. For some of the folks in the States, it's to take advantage of being able to get a lumpectomy when they might not have been able to previously. But in addition, it's also because of at least some data to suggest there may be some survival benefit. But like I said, if you look at the NCCN guidelines, it does not weigh that heavily in favor of neoadjuvant treatment quite yet.
Okay, thank you. Dr. Siegel, please.
Yeah. Dr. Siegel, can you tell us more about the mama print test? Because I think it could be good for us in the department. The mama print test.
So I'm sorry to tell you a little bit more about what I missed that part.
Yeah, can you tell us more about the mama print test?
The mama print. Sure. So mama print is like a few other similar but slightly different molecular genetic assays that we have available to us. So when it comes to analyzing tumors in general, you know, in the States, there are labs that have developed that can look at 600 plus genes and tell which ones are turned on and which ones are turned off, and HER2 would be one of many of them. And sometimes you can tell by which genes are turned on and which genes are turned off. There may be a target there for which we have a targeted molecule that could work. That's not what these tests are. These tests have a much more limited profile. So, you know, if you go back early on, when people first started doing this research, they would take breast tumors that they knew the clinical outcome for, and then look at those breast cancers and see which genes were turned on and which genes were turned off. And ultimately, they were able to describe a pattern that if certain genes were turned off and certain genes were turned on, it would behave clinically in one way. If there were a certain mix another way, the tumors may have behaved a certain different way in terms of drugs they responded to, in terms of drugs that they didn't respond to. And ultimately they could create a pattern looking, and then they could narrow it down to a specific panel of genes that were important. So they don't have to do all 600. In one of these assays, it may be 30 genes. In another assay, it may be 21 genes. But they look very, very closely at those genes to see which one is turned on and which one is turned off. And by virtue of doing that, they could classify that tumor. And based on what they had looked at retrospectively, they could then give you an indication of what could happen prospectively based on the patterns that they had established from their early research. And so that's what MammaPrint is. We send a tumor into that lab. That lab looks at a specific group of genes to see which ones are turned on and which ones are turned off. And once they've done that, they can say, based on our experience from the past, we would predict that this person on average has, a 95% risk of, or a 95% likelihood of staying free of disease if you treat them with chemotherapy and hormone therapy. And in another situation, they may tell you that this person has a 95% risk of staying free of disease, but they just need hormones. And so you get a sense of prognosis, and you get a sense of, so it's a little bit predictive, but it's also a bit prognostic as well. It's prognostic and it's predictive because it can also tell you which kind of drugs to use. So does that help at all?
Yes, it does. And so do every patient in the US benefit from the mama print, or is it?
No, we don't order them on everyone. So for example, if someone is HER2 positive, we already have a sense of how we need to treat them, and so that person would not get a mamma print. If somebody had 5 or 6 positive lymph nodes, they probably wouldn't get a mamma print. On the other hand, if somebody presented with a very small tumor and very high estrogen receptors, as I said, we can oftentimes tell what a mamma print is going to tell us, based on certain biochemical criteria that we can get fairly easily. And at least in my personal practice, I don't send a mamma print off for those. It's really those patients who may have one lymph node positive and whose progesterone receptor may be a little bit borderline high or low that I'm not sure. So I would say that the majority of my patients don't get mamma print, but there are certain instances in which it's helpful. And other people may practice completely different. I'll tell you, in the United States, it's probably all over the map, but it's there to help us when we need it.
Okay, so can we say in some ways that at least the way some people use the mamma print to avoid some form of overtreatment, or is it right to say that?
Yes, and in fact, you could work for the mamma print people because that's how they sell it. It is meant to minimize cost and minimize unnecessary toxicity for patients who don't need or wouldn't benefit from chemotherapy.
Okay, I'm just going to translate that for the team. Déterminer comme si qui traitement qui approprié, donc pour éviter de pas avoir un traitement qui pas nécessaire. Okay, thank you.
Yeah, we'll see.
And Manley has another question.
Yeah, Dr. Siegel, in the lecture, you tell us to give chemotherapy to the patient triple negative breast cancer that is more than 2 centimeters. In Haiti, what will you suggest us? Because some patients, we don't know the immunochemistry before before we perform surgery. What?
Yeah, so I don't know that there's one answer there, and you are in a unique, at least compared to the United States, in a unique situation in Haiti where you are behaving somewhat blindly in terms of decisions that have to be made without any of this data in front of you, and yet you have a patient who needs something. So, if I think back to some of the cases I have helped you all with in the past, my sense of things is that if you happen to come across someone who has a mass that does not seem to involve multiple lymph nodes and doesn't seem particularly large or distressing, you can wait for the results to come back to manage that person. On the other hand, if someone has a very large tumor and involving lymph nodes, and you don't have anything back, clearly it's a little bit more likely that that tumor is going to be estrogen receptor negative, just statistically based on how it's behaving. And two, if they are having some kind of distress from this, whether it's because of bulk or size or ulceration or something else, there's no reason, regardless of what the estrogen receptors say, there's no reason not to start chemotherapy on that person initially just to manage symptoms. The ones that are in between those two, those two ends that may be in the middle, it's always something that we have to decide with you together, largely because we have to look at the patient and how healthy are they, and are we at risk of this becoming non-surgical if it grows some more and does so quickly. I would be on the err on the side for bigger tumors to just consider chemotherapy initially. Again, if we're talking about non-metastatic disease, to consider chemotherapy first. For the patient in whom you can wait a few weeks, what we have done for some of those folks is to put them on an endocrine therapy until we have the information back. If it turns out the endocrine therapy wasn't correct, then we can always make decisions about going forward with the chemotherapy. But more often than not, the patients that we're thinking that we need to do something quickly are people who have bad disease, and those same people probably would benefit from chemotherapy first, even without the estrogen receptors.
Yes, to follow up what Manley asked about, I think it's one of the issue that your presentation underlined is the need for immunochemistry as soon as possible for us. That's one of the things we have to work with rapidly. And I know that the lab is working on that to get it as soon as possible, because like you said a couple of times, the way we are working right now, we are providing care is in some ways blind to those factors, which are hormones or molecular positivity. And that would be great to work on a way to get that as soon as possible, to be able to at least follow the algorithm tree that there may be available, like the one which is showing right now, to be able to act. So that is something we really have to work on. And even like the case you presented, more than 2 centimeters, this patient will probably have a surgery at atrium, and then adjuvant chemotherapy. Right. So maybe if we will kind of show that we will have the immunochemistry in, let's say, 2 or 3 weeks, depending on the clinical state, we could decide to wait and to reevaluate in 3 weeks. But since we know for now it may take months, we act immediately. And the other takeout, I would say, is more national than institutional, is that many of the cases, the first 3 cases, like you said, very unlikely to happen here, since we rarely have screening mammogram. But when we look at the numbers, the likelihood of success of treatment and life expectancy, it's worth the case. It's worth the try to aim for that. So thank you very much, Dr. Siegel. A lot of takes that we had, and a lot of things to learn also.
Well, I hope it was useful to all of you, and you know how to reach me if you have questions after you've looked through it again, or colleagues of yours have opportunity to look at it later. I'm happy to help. Hubert, do you have any business items before we sign off here?
No, just so thanks for a great lecture. It's good to see you, Bob, and it's great to see the Haiti team as well, and our colleagues, Dr. Millien, Dr. Ellis, good to see you as well.
Yeah, Bob, that
Thank
was
you.
that was a great talk. Thank you so much, and thanks for the Haiti team for showing up. It's great to see such a large audience this morning.
It was
Thank you.
Yes.
Thank you so much. Thank you, Professor. In the name of the HRM team, I really thank you for this wonderful session this morning. We appreciate that. And we have
I
learned a lot.
appreciate it. I appreciate it. You're more than welcome.
Thank you so much.
Bye-bye.
Bye-bye all.
Bye-bye.